Looks like he's joined us. Hello, Leo. Great to see
Hi,
you.
good to see you too.
So thank you so much for joining us. To our scholars who are online and our alums, Leo Morales, or Dr. Morales, I should say, or Dean Morales, I'm not sure which you prefer, but was in our first cohort of RICMAR scholars back in 2002 to 2003. He was on the faculty at UCLA in the early 2000s, and then transitioned to the faculty at University of Washington. And one of the things that whenever I think about Leo, I always remember is when in 2001, the RFA for the new RICMAR centers joining the old ones came out. He had a meeting with me and brought the RFA with him and said, Carol, we really need to do this. I'm too junior to lead it. And I was wondering if I could get you interested. And the rest is history. I mean, it really, Leo played a really key role in encouraging me to apply for the RICMAR. And I know this looks ridiculous today, 20 years later, but it was a big, huge step for me at the time. I had only had, 2 R1s and just got, I was an associate professor, and I just didn't think they would ever give it to somebody as junior as me. But I think with a lot of encouragement from Leo and from Keith and from others, certainly Billy Cunningham, some of those people who were in our first center, I'm probably forgetting some, Jeannie Miranda played a role. And with the help of everybody, I was able to pull together this application. But to this day, I feel like the reason why we got it was that the first 3 scholars that we proposed were all so phenomenal and on such great trajectories already, and really showed the kind of people we could draw into the center and help to develop a little bit, because they were already so good, that would really put our site on the mark. And even though we were coming in with the other centers all in a competitive renewal situation, they were all entering their second 5 years and we were the new center. And it's really to the credit of people like Leo and Arlene and Marie Fangwa that we got established. I forgot to mention Ron Hayes. He also was in that very first group running our analysis core, and Gary Ryan was in the analysis core. And you can see how stable the team has been over the years, but it was to the credit of all of those people that we managed to be successful. So I'm not sure if Carol Najee has joined us or not. I know she was invited, but Carol was, one of the early administrators who really also just helped keep us organized and get that all launched. So Leo has had a great career. He was doing health disparities research before we probably even called it that, but really focused early on the very critical issue of what I'm going to call language disparities, so linguistics disparities, where he was really one of the early people to do very meticulous studies that showed just how hard it was to get good quality of care if you were not an English speaker in the US healthcare system. And the value of interpreters, but also the value of doctors who are culturally competent. And I'm not doing his CV justification, but I think that early work really made a huge impact on the field. And I think that later on, certainly seeing Leo go into more of a faculty development role at University of Washington, probably one of the earliest EDI deans in the country, actually long before the bigger trend happened. Leo was in his position. And so I'm not going to waste any of his other minutes. I'm just going to thank him for joining us and tell him how honored I am that he accepted our invitation.
Yeah.
So thank you very much.
Oh, thanks, Carol. And it's really my honor and pleasure to be here. I always, my experiences at UCLA were so important and formative. I use what I learned and the experiences I had there every day, every single day, and the work I do today. So it's really great to be able to come back and share a little bit about what's been going on in my life since then, and to be here with you today. So thanks for having me. I'm going to go ahead and share my screen here. All right. Can you see that okay? Yeah, good.
Yes.
All right. So the Great Northwest, this is Mount Rainier, and this is one of the reasons I came back. So I just thought for those who don't know me or my background, I'd just quickly go through kind of my career journey and the winding road that it takes and has taken. So I'm originally from Seattle. My parents are immigrants from South America. I was born and raised here in Seattle and attended UW, graduated from UW as an undergrad, and then subsequently actually started my MPH prior to my MD degree. I was not one of those people that knew they wanted to be a doctor. I kind of I really even started seriously thinking about medical school towards the end of my undergraduate work. So I started in with public health and then ended up combining my MD and MPH. I was really quite fortunate to get accepted to the training program at San Francisco General, UCSF in San Francisco. It was just an exciting place for me to go. It was really the first time I found a cadre of people like me. Tomas Aragon, who is now the director of health for California's Department of Health, was the chief resident when I was interviewing there. And when I met him, I was just like, wow, I want to be this guy. I never really met somebody like him. And it was so exciting. So I was really, really psyched when I was able to be accepted into that program. I ended up staying in the Department of Public Health. Like many graduates from the UCSF program, I think we needed at least a year to recover. It was a hard program. And so I spent 2 years in the health department and really got my first exposure to managed care at that time. And got involved with the implementation of managed care under Sandra Hernandez, who you probably also know from her foundation work in California. But I worked for her along with providing care in one of the community health centers and also at San Francisco General. And I realized I really wanted to learn more about health economics. I was a chemistry undergrad. I never really even had an econ class, and I realized that financing and economics were really important to what happens in the delivery of healthcare. And so I was attracted to the fellowship at UCLA. And in particular, I was really interested in what was going on at RAND. And so I came under an NRSA fellowship in 1995 and enrolled in the PhD program in policy studies at RAND. So I was a fellow for 3 years and then joined the faculty in 1998 and then completed my PhD a couple of years later. So the 2000s were about, becoming a Chime Fellow and then subsequently a faculty member. I was awarded an RWJ Emil Scholar Award. I was also awarded an RWJ Health Policy Scholar Award. I was able to get promoted and I was enjoying my work. I was doing very much what I would call more basic research, not a lot of applied work, some community engagement, learning about community and the importance of community engagement. And I really wanted to do something different. I wanted to do some research that was more applied, and I also just wanted to come back to Seattle. So. And I'll talk a little bit more about that. But so I moved to the Group Health Research Institute initially in 2009, and then to UW in 2014. And also with concurrent with my moving to UW, became a co-director of the Latino Center for Health in 2014, which I'll talk a bit more about. So I've done, I've moved around and done different things. So I just thought I'd go through a few reflections. So on leaving UCLA. So why I moved? Well, like I mentioned, I wanted to try new things. I felt a little bit stuck in the ivory tower and kind of wanted to just spread my wings. I wanted to do new things. And I was feeling like I had consolidated my skills and I was ready to go out and do some things, do something new. I wanted to tackle issues related to health disparities in a more applied way. So I wanted to use my skills and my knowledge and the policy work I had done to really try to affect a change. And I wanted to come back to Seattle. So my son was about to enter middle school. I realized I better move him soon or I'm not going to be able to. And I had aging parents. My father subsequently passed away and my mom taking care of her. And that's what I came back to do. And so that's been very gratifying. But what I miss? Well, UCLA was an incredibly supportive and nurturing environment. And, you don't know these things until you leave. And I realize now that it was a very special place at the time that I was there, and I'm sure it still is today. And so for those of you who are there, I just, want to share that with you so that I think that you probably are having the same experience I had. I was surrounded by colleagues who understood what I was doing and why I was doing. And that really solidified a sense of belonging and identity for me as a physician who does research, and I that gave me a lot of sense of direction. And of course, Los Angeles is just a fantastic place to be, and that's coming from someone from Seattle, right, and Northern California. When I moved to LA, I was like counting the months. Pretty soon, months turned into years, and I really grew to appreciate LA. Its multiculturalism and its Latinidad that's there was really invigorating and just, again, very affirming. And of course, my mentors. And I think all these individuals, Ron Hayes and Carol and Jose Escarce and Martin Shapiro and David Hayes Bautista and Billy Cunningham and others, were really key and important people in my life, and forever I am thankful to them for the support they gave me while I was starting my career. So I spent 5 years at Group Health. Actually, let's just say 2009. Sorry about that. And so I just kind of tell you a little bit about that experience. So now Group Health is known as Kaiser. Kaiser bought Group Health, so Kaiser Washington, and Carol's sister now leads the Research Institute at Kaiser. And we didn't overlap there, but I know a little bit about the institute. What I really did enjoy was many new ideas. Physicians and social scientists really working to improve healthcare was something I was looking for and learned about. I also was for the first time exposed to a health system culture as opposed, that's really focused on delivering healthcare as opposed to a university environment. So it's more, if you will, corporate and more business oriented, and really has to do with, delivering care. That was a new environment for me. I really enjoyed the fact that there's a natural laboratory for rich data there. And I had an opportunity to really dig into community engagement by my leadership of a core. ITHS is the equivalent. I think you have an equivalent center that's NIH funded to kind of it's the resource center. I can't remember the name of it right now, but I got the opportunity to lead a community engagement core, and I really focused on the Latino community in the Northwest, and it was really the beginnings of the Latino Center that was subsequently formed. But what I was missing exposure to trainees and fellows, and what I call small research. So small research to me is ideas that come up, and with whatever resources you have available, and with willing people and interested colleagues, you can do things. You can do small, projects that are innovative and interesting. And I think, a place like group health really requires larger funded projects. Wasn't as easy to do. And at the time, there was just not people there. And I think maybe that's why it was brought on, was to help orient and bring the Institute around to health equity. So this is, prior to, the world has changed in terms of health equity. And at the time, there just really wasn't much of a focus before ACA. And so I kind of was like a fish out of water a little bit. And what I really didn't like was the grant treadmill. And it was very, competitive. And just writing grants all the time just felt like this is not sustainable. So I wanted to change things up. So I accepted a job as Chief Diversity Officer for the School of Medicine in 2014 and moved to the University of Washington. And really, this was probably the most challenging thing I've ever done. And just to give you some context, first of all, didn't have really any sort of training for this. Although I had training for a lot of things, I didn't have this specific. There's no Chief Diversity Officer school. And so it was new. The school had a lack of, had a lack of diversity in its students, its trainees, and its faculty and administration. There was ongoing and growing, and is still, a significant amount of discontent with the curriculum, a curriculum that doesn't reflect a more diverse student body, and one that doesn't address the issues that students are concerned about. There was a general lack of trust between students and faculty. Of course, the Trump campaign in 2015 and election in 2016 created a huge amount of electricity in the environment, made everything volatile, and the appropriate attention that came about through the Black Lives Matter movement and the deaths of so many at the hands of police really, I think motivated students to stand up to institutions, including medical schools, that were not doing what they should be doing, not educating physicians for the future, and certainly not dealing enough, and I'll say for UW in particular, kind of stuck in the old paradigm and not understanding the role of population health, of racism in medicine, and doing harm to students. And of course, as Chief Diversity Officer, you become the lightning rod. But I will say, appropriately. I mean, and I think those changes, I'm sure, have been felt at UCLA as well, and throughout the country. And medical schools are like tanker ships; they take a long time to turn direction, and it's much needed. I have really enjoyed having the leadership experience. I have enjoyed having impact through directing resources. And I've learned that being at the table is really important. And as somebody is, in this role, I was at the table many times, but not always. There are still tables of power in the university that are not accessible to folks who are involved with diversity, even though they should be. And so that's just something to learn. What I really didn't enjoy was feeling like all decisions were contentious, that it was, this is partly the contextual issue. It was very challenging. Having to deal with really difficult student, faculty, and staff situations that had to do with racial equity and discrimination. And for myself, I'll just say, lack of mentoring. So I came from an environment with lots of mentoring, and I was somebody who benefited from that and shared mentoring, but I was now in a new position that there was really no one there to help me. And it was a struggle. I had colleagues who were supportive and helpful, but true mentoring was hard to find. So last summer, I was offered the opportunity to focus more on healthcare equity in the healthcare system. So UW Medicine has a medical school. It also has 3 hospitals and neighborhood clinics. And I think this was a good move for me. I felt like I could use some of the skills I had in terms of policy, in terms of research, and I had learned a lot about how the healthcare system works just by serving in the medical school. And so I took this role as Assistant Dean for Healthcare Equity with a focus on addressing healthcare disparities. So I've been involved with a lot of health system-wide training on social determinants of health and health inequities, something I'm talking about patient experiences and technical aspects of quality of care like HEDIS, lots of things that I have in my background. I'm involved with projects to reduce healthcare inequities. I'm doing a lot more community engagement, and I'll talk a little bit more about that. And I'm going to just share with you a couple of projects that I've recently been involved in to kind of show the direction of the work that I'm doing now. One is the Latino physician workforce study that kind of overlapped my 2 roles, and then more recently responding to COVID-19, and a project called Adios COVID. So I'll start with this Latino workforce study. This really kind of overlapped with me as diversity officer, but carried on in the last, has really been ongoing. The Latino Center is co-directed by myself and Gino Eisenberg, who's actually born and raised in South LA. Family is from Mexico, and has been at the University of Washington for about 15 years. We overlapped briefly at UCLA. I think we met, but he knows he knows Jeannie Miranda and Jürgen Unitzer and others who have passed through UCLA. So we had these connections. They seem to come up all the time with UCLA. So our center is a multidisciplinary center that's community engaged. Our mission is to improve the health and well-being of Latinx communities in Washington. And we are funded by the state legislature and by project-related grants. But we have this core funding from the state legislature. And let me just say this whole center came about because of, we had some very early seed funding from the School of Social Work, School of Medicine. But it was community supporters, previous ex-legislators who got together and decided they wanted to help fund the center, and went to the state legislature and created a funding stream, which we get from the state, kind of akin to David Hayes Bautista's center. And that's what really gives us our core funding, and we are responsive to our legislators and the people that they serve. So we're very connected to the communities in our state. Just to give you a sense of this project, we were an interdisciplinary team with people from many different disciplinary backgrounds, and many Latinos. So we are a Latino center with lots of Latinos doing policy research, and it feels really great. Maggie Ramirez is somebody who you may know, passed through UCLA a little while ago. We were able to recruit her back to Washington. And we were, and again, this project was funded by a proviso. So we proposed this to the state, to a couple of legislators who took it up and said, yes, we want you to do this. And they created some funding for us to do this project. Our goal was really to inform. So, data is important. Sharing data is maybe more important. And then ultimately creating policy, changing policy is the most important. So we, by intent, our goal was to change policy. That's what we wanted to do. And we planned the project accordingly. So we created a project advisory board, and really this was to help us with policy from the beginning. And just to give you a sense of who they are or who they were, we had people from foundations, we had representatives and senators from state government, we had representatives from larger healthcare systems like Kaiser, and importantly, we had representatives from each of the 3 medical schools in our state. So Washington State University, PNWU, which is an osteopathic school, and WAZU, which is Western Washington University. We also had a representative from WISMA, which is the Washington State Medical Association. We had a representative from an international medical group, International Medical Graduate Group here in Washington State as well. So we really poised ourselves to do policy work. I'm going to just share some very brief highlights from the study. What we found is 3% of the physician workforce in Washington State is Latino, identifies as Latino, which is about 45 per 100,000 Latino population, as compared to white physicians, which are represented at a rate of 277 per 100,000. It's just dramatic. Only 11% of Latino physicians in our state are trained in our state. The rest are from either out of country, foreign trained, or out of our state. So a full 25% are international medical graduates of Latino physicians in our state. And as we were talking, language is so important. Linguistic access is so important. Nearly 25% of Latino physicians report speaking Spanish well enough. 75% report speaking Spanish well enough to communicate with their patients. 25% of those, or nearly 25%, are those foreign medical trained physicians, as compared to non-Latino physicians only, which about 13% report speaking Spanish well enough. So Latino physicians are responsible for a lot of the linguistic and cultural access that patients and Latino patients in our state get. And a large proportion, 40%, report on providing care to patients with Medicaid or Apple Care in our state. So I just want to give you a sense of where, so interestingly, this is Western Washington, this is Central Washington. This is a big ag area, and this is where counties with the highest proportion of Latinos are. So, believe it or not, one of our counties here is 65% Latino. And these are not the areas where the most Latinos live. That tends to be in these more populous counties like King County, Pierce, and Skagit counties on the west side. And this is where Latino physicians are located. Each of these dots represents one of them. And what you'll find is that the west side has a high concentration of Latino physicians, but Central Washington, where you have these high proportion Latino communities, not so much. And in fact, the proportion of physician, or the ratio of physician to Latino population in these counties is quite low. And over here, the shading kind of gives you a sense of how low it can go. It's also where we've had the biggest problems with COVID. I'm just going to say, I just wanted to focus on these first two bars. We have currently 462 Latino physicians. In order to reach parity with the white physician to population ratio, we would need to add 1,885 Latino physicians tomorrow. That's the degree to which we're underrepresented in the healthcare profession. And we would need to be growing our Latino physician workforce to be on a positive trajectory at about 12 to 15% before we even, so you have to remember the Latino physician is expanding, our population is expanding. So we need to be growing at that rate to even make a positive change towards better representation, which is a tall order to ask for. And I'll just say, so briefly, 2021, we set out 3 policy areas that we wanted to work on for the legislative cycle. Remember, this is the context here is we're coming out of COVID. The state is projecting 15% budget shortfall. So we decided to focus on policy recommendations that we had developed that would be basically cost neutral. And there were 3 of them. We wanted to have a law that said written into law that medical schools should reflect the populations that they serve, that residency programs should do the same, and that there should be a pathway for international medical graduates to residency, because we recognize the importance of international medical graduates in serving Latino communities in our state. The context here for these representational goals is really, I-200, which is the anti-affirmative action law we have in our state. And, the medical schools are very risk averse. And what we wanted to say is, but there's nothing in I-200 that says you can't have a goal. These are not quotas. These are not slots. What it says is we need to look like the people that we serve. And we thought that would help clarify for medical schools that they need to be striving for this. And so this is what our policy goal looked like. This is what came out of our report. And we actually saw it come to fruition. So SB 5228 was passed this year and signed into law by the governor, and sets forth a requirement that medical schools work towards better representation of the communities in the state of Washington, and that they report on a periodic basis on progress towards that goal. We did not get a similar statement around residency training programs, but this was an important step. Then we worked with the legislature. We testified in front of different committees at different points in the process of passing legislation to help support. So our report was important in supporting the movement of this legislation, which includes more than just this. It includes also cultural competency training for practicing doctors and for medical students. The second one, the creation of the IMG pathway, was a second policy recommendation that we chose to support, and resulted in part in the passage of HB 1229, which creates a limited license for international medically trained graduates for a possibility of 3 years. And this is time enough to develop experience and prepare for residency applications. So it doesn't create a new workforce. It simply is a temporary license that is part of a larger goal to create this pathway. So we had some success. We have other policy recommendations that we did not pursue. We did have a goal to create a statewide Latino physician organization in Washington, and WISMA, which was part of our policy committee, stepped up and has created this. So we have the first ever statewide Latino physician organization as a section within the Washington State Medical Association, and we're currently working towards formalizing that group to really create networking and policy advocacy at an organized physician level for issues that are related to Latino communities. And we shared the results of our report in a symposium. So we culminated in a symposium that was around late fall, just going into the legislative session. We did this online, and so this just gives you a sense of some of the people here you'll recognize. Efrain Talamantes was one of our keynote speakers, so was David Hayes Bautista, and we had representatives. We had the president of UW support our report and its findings, and we had various other individuals from the community, patients, and providers, and it was really fantastic. And we have ongoing work for the coming legislative cycle and beyond. Our next focus is really going to be on the community college to health sciences pipeline. Again, we need to diversify the way that our students come to the health professions, and we have some great opportunities in community colleges to do that, along with some other goals, including our work on the pandemic. And we had some art done for the project, which was really cool. So, and a dedication to future Latino physicians in the communities they'll serve in the state. You can find the report on our website, which is just latinocenterforhealth.org. So moving on to COVID-19 and adios COVID. So I know you all know, this pandemic has shown us how much our country suffers from inequitable healthcare and inequitable health conditions for health. And, this is one of many studies, but I think it's striking to see the impact that the pandemic has had on life expectancy. And, these bars on the right-hand side show you the loss of life expectancy for non-Hispanic Black males, Hispanic males, non-Hispanic Black females, and so on. And it's just tragic and sad and possibly preventable. But we need to do a lot of work. We need to make a lot of changes in order to change this situation. In our own state, Latinos have accounted for between 30 and 40%, depending on the time frame you look at, of COVID cases, even though Latinos only represent 13% of the population. The overrepresentation among the cases and the mortality have been elevated for African Americans, for Native Hawaiians in particular. And this just gives you a sense of age-adjusted rates of mortality in our state. So Latinos almost, I think currently it looks like about 3 times the mortality rate among whites. So these are age-adjusted. This is not just case rates, these are mortality rates. And for African Americans, twice that of whites. For American Indians, almost twice as much. And for Native Hawaiians, almost 4 times at this time period. So huge impact. Huge disparities. So I'm sure many of you, another proud product of UW is the IHME, the health metrics group model, which I watched, I'm sure you watched, to see what was going on with the pandemic, what was going to happen in the future. And this is the model for Washington State, sort of capturing a period in time. And you can see where sheltering in place was put into order. And, we saw that it was at the time of this initial rising peak of COVID infections. And then you see this nice decline and, reasonable, right? Lift sheltering in place. And that's an important story, and that makes policy sense. But when you look at the disaggregated data and what's going on with different segments in our state, you can see a very different story. So each of these represents a different racial ethnic group. These two upper lines here are Latinos and Native Hawaiians and Pacific Islanders here. Shelter in place had no effect, none whatsoever. And in fact, one could argue it even made things worse. Rates just continued to climb. And in fact, they continued to climb after sheltering in place ended. And it was only in the period that followed that you began to see declines. And they didn't decline down to the baseline of other groups. And then you see a second surge go on. I think this tells so much about how policy decisions are made, how on averages, without really understanding what's going on in different communities, our experiences are not all the same. We are unfortunately in a segregated society where different individuals have different experiences depending on where they live and who their social networks are, what their job opportunities are, what their living situations are, how much knowledge they have to protect themselves. All those social determinants of health are at play here. This story has yet to be told, really is beyond what I'm showing you here, but I think it's an important one to tell and to try to understand. And why did it drop afterwards? What happened? Coming a little closer to our own home, King County, we saw the same kinds of case rates and death rates here due to COVID in our own county. And I would just say King County is a highly resourced. Our health department has more funding than the state health department. And so to see these kind of disparities happening in our own county just tells you how embedded and how entrenched social determinants of health differences are. So very early on, I became aware of inequities in testing. So what you see over here is King County, and this is sort of downtown Seattle here. So there's, this is where communities of color live in South Seattle. And the story really is that where testing was occurring was North Seattle, but where the pandemic was raging was South Seattle. And I tell you, I watched this and monitored this from the beginnings to even through today, and the same picture. You'll see the same exact picture. So what does that mean? It means that an important health resource, the testing that needs to occur in order to identify cases, in order to isolate, to quarantine, to provide treatment, to refer, is not happening in South Seattle. The history to this is really interesting. So Seattle had redlining. There was basically a red line drawn south of downtown, where it was not possible for non-white individuals to buy property in the northern parts of Seattle. And so, that is no longer enforced. If you look at deeds, they still reflect this, as they do in LA. Our deed had something. I lived in Culver City, and there was a statement there that was basically excluding, I think, Jews and other non-white groups. I can't remember the exact language, but it was there on the original deed. But these are the historical remnants that continue to impact and create health disparities today. And COVID just shows us this. So why are we not? And I will tell you, the government's aware of this. King County Public Health was aware of this. UW Medicine was aware of this. We deployed mobile testing teams into South King County, and still we were not able to reverse this situation, even to this day. And so so I was trying to think about, how can we measure equity? How can we map equity? And so there's this great example out of LA that was published. I think this was published in LA Times. And basically it just tells you a very simple story. It tells you, this has to do with vaccinations now. What is the vaccination rate and what is the infection rate? And there's really two communities here, Beverlywood and Commerce. Beverlywood is a much less diverse community than Commerce. Commerce more diverse, lower income. And you can see here that the COVID case rate in Beverlywood is about 6%, and the vaccination rate at this time, which is early on in the pandemic, was about 17%. And exactly the opposite when it comes to Commerce. 8.6% vaccination rate, but 17% case rate. So there was a lot of interest in SVI, the Social Vulnerability Index. And I was thinking, what really matters. So we know that communities of color have higher social vulnerability. But what we really need to pay attention to is infection rates, right? We need to vaccinate where there's infection. That will coincide with vulnerable communities and communities of color, because that is where the infection is greatest. It's also not static. So SVI tends to reflect the past, doesn't really change with the vaccination, but infection rates should reflect and respond to vaccination. So I got interested in this issue and started we did some mapping at UW Medicine, and this is UW Medicine patients only, but we were able to see on this side where the highest rates of infection were among our patients, and where we were doing the most vaccinating. So it's a little hard to discern, because you see higher rates of infection in North Seattle and South Seattle, but you see higher vaccination rates in North Seattle. And relatively less in South Seattle. So there's a story to tell here, but we really wanted to hotspot where we needed to go in terms of mobile vax in particular. And so it's like, how do we put this together, and how do we show disparities? So here's what I came up with. This is a map of the difference. So what I did was difference infection and vaccination rates, and then compute a Z statistic for that difference. And so what it is gives you is an average, which is the average difference. And then you have zip codes that are then z-scored. So you can see those places that are less vaccinated relative to infection rate versus more vaccinated relative to infection rate. And what resolves in this picture is where the greatest disparities occur between these two rates, vaccination rates and infection rates, thinking that equity is really vaccinating where the infection rates are highest. And of course, South Seattle shows up as being the most under-vaccinated relative to infection rates. And this is still true today. So again, so we saw it with testing. We knew it was coming. We were talking about the issue. We were saying we need to do better when it comes to vaccination. And yet here we are, and we're doing it again. So for the, and that's UW medicine patients. So it's like, so why does this happen, right? Like, so why do we do all this testing in North Seattle when there's more disease in South Seattle? And why do we do all this vaccinating in North Seattle when we know we have higher infection rates in South Seattle? And this is where our facilities are, right? This is South Seattle. This is North Seattle. More affluent communities, less affluent communities, right? Tells the story. And you know, so this is the, I think the fundamental issue is, you know, we need to invest in communities that need us. We need to be there. We need to go there. And without our presence and without our investment in lower income, more impacted communities, things aren't going to change. So, so that's kind of where things are. I mean, that kind of is the way it is. And I'm sure you have similar stories to tell in LA. And finally, I'm just going to share with you a little bit about Adios COVID. So Adios COVID has been really interesting. I have, you know, been working, you know, I get some media attention. So I've been talking in the press. And one day I got a call from Frank Martinez. He said, hey, I read about what you're doing through the Latino Center and vaccinating. You know, we're doing testing and trying to do some vaccinating in South King County. And he said, I'm a high school faculty member. So the way he introduces himself is like, I'm an high school faculty member who's ex-IBM, ex-Microsoft, and I'm an angel investor. And I'd like to work with you on vaccinating Latinos in our state. I'm like, okay, what does that mean? Are you going to give us a lot of money? What's going on, right? And he's a native from Sunnyside, from sort of, you know, this is the Yakima Valley area. And it's just interesting. He just starts talking to me about what he's doing. He's developing a platform and he needs help, right? He doesn't know how to make his platform more usable. And so we just start talking, meeting. And what I realize is the way he works is he invests himself. So he's one of these high net worth individuals who, you know, made it good with tech and now kind of takes on social projects that he thinks are important and kind of invests himself. And he has a team of people that he brings to bear on projects. So we set this lofty goal. We said, we want to vaccinate 1 million Latinos, basically all Latinos in the state by the end of 2021. And this is going to be our approach. So we are going to partner with CBOs. So you know, the thing you recognize, what I recognize is UW Medicine was doing a great job with its patients. You know, CMAR Community Health Centers was doing a great job with its patients, and they were holding on to the vaccines that they had for their patients, which is their responsibility. But when it comes to the Latino community, many are uninsured, unconnected, don't go to healthcare, and are therefore excluded. And so who are these individuals connecting with? They're connecting with these more grassroots organizations. They can be social services organizations. They're promotoras who are grassroots through the school districts, perhaps, because their children are in schools. And so we can reach out to those families through the children, mental health, substance abuse, all kinds of different, but not healthcare organizations. We need to work with them. That's the gap we can fill. Frank wanted to make sure we had an accessible digital platform. So we realized that, you know, early on, I'm sure you had the same sorts of feedback. These web-based registration, vax finding systems just are not accessible to people. So we wanted something more simple. We wanted to make it SMS based and it had to be Spanish. Frank has a lot of connections, so we got partnered up with the state DOH, and they actually they have made resources available to us. So we now have a mobile vax team that we can deploy when we approach a CBO. So it's kind of me working through the Latino Center connections in the state with grassroots organizations and just kind of approaching them. And it's interesting. You just have to say, how can I help? And people are like, oh yeah, we need this. And we can do what we need to do. And of course, working with Spanish language media statewide to share information. So we've been holding a lot of different panels in Spanish through Univision in the Northwest, through radio stations and newspapers to share information about where and how you can get a vaccine, and also just about vaccine safety and efficacy. So this is what Adios COVID looks like. You can go to it by Googling, or just type in adioscovid.org, and it'll pop up in Spanish. You can switch it over to English up here, and basically just fool around with this. Text. You can text Adios COVID, adios. You just type adios, and it will return to you. It'll ask you for where you live, your zip code, and then it'll return to you places where you can go get vaccinated that are within some radius of where you live, so that we wanted to make it geospatially specific. So regardless of where you're in the state, here's how you can get there. There's also other resources that are available through here. And Uber is an interesting story. Uber has donated a bunch of these free lifts, but no one's taken them because Uber doesn't work in lower income communities that well for a lot of different reasons. But it's been kind of interesting. So yeah, check that out. And I just want to say, so here we are. So this is June 9th data. Washington's been touted as being one of the states that's, doing well in terms of vaccinating. But what I did was just take the counts of those vaccinated by county, compare them to the census data, and these are the rates I get. So these are all Latinos, not just 12 and older, because, the virus doesn't care how old you are. It just knows whether you're vaccinated or not. And this is where we're at. So in these counties, particularly some of these counties in central Washington, where there's a high proportion of Latinos, 20%. That's a long ways to go before we're done. And I'm really concerned about what's going on in terms of turning our attention away, again, doing what I showed you with the stay at home, right? Like overall, things look great, but in specific communities and specific places, some of them smaller, we are in need of great attention, or we're going to have a big problem with the Delta variant in the fall, and schools coming back together, right? Lots of vulnerability. So this is I'm preparing this for a policy brief that should come out sometime, hopefully this week, because we need to not move on too quickly. Yeah, and here's the King County, 70%, I think they're touting, of eligibles are vaccinated. But if you look at the vaccination counts versus the census counts, it's only about 37% of Latinos in the county who are fully vaccinated. So that's a little bit about what I'm up to, getting into trouble, good trouble, I think. I have a sailboat. This is it right here. It's called Wizard. And this is what I do on Monday night. So after we finish, I'm going there. And I'm going to go race my boat on Puget Sound. Feel free to reach out to me. I love to talk to people from UCLA. UCLA is a special place for me. So, and you can also follow me on Twitter. So I have a Twitter feed that I feed once in a while. And I'm happy to answer any questions or take comments.
Well, thank you, Leo. That was phenomenal. And you're having an enormous impact at your place. I think one of the things that is very striking about your story is how good you are at quickly pivoting and addressing problems in a big way. And I think, you know, a lot of people who think in the framework of writing the NIH grant to be able to get the problem done, sometimes miss the opportunity. So you know, I think your last story in particular was a really fine narrative and example of that ability to pivot. I'm going to look in the chat here to see, or people can just turn on their mics and ask questions too, if anybody would like to start the Q&A part.
I'd like to ask a question.
Go ahead.
Okay.
And
Leo,
please introduce
it's Leo
yourself.
too. It's Leo too.
Oh, no.
No, sorry. No, Leo, it's Ron. The last thing you said there about the rates for Latinos being so low, can you say anything? I don't want to be specific to that group necessarily, but just about the reluctance, because it's always surprised me how much reluctance there is in general to get the vaccine. So how much of it is due to that and how much is due to other factors?
Oh, hey, Ron.
You know, I was kind of wondering who that was.
I recognize
I thought we had, like, you know, one of those Zoom bombing things going on here.
It kind of is. No, great question. And, you know, it comes up often. And, you know, so here's what I see. I see, so some reluctance and questions around concerns are normal and expected and present in Latino communities like in all others. But a lot of what's going on is got to do with other sorts of concerns that are related to receiving the vaccine. So either access, particularly around cost. So there's a lot of still misunderstanding. There's also misunderstood costs, like taking time off from work and finding someone to take responsibilities that you need. I mean, for many people in the Latino community, and specifically, you know, losing a day of work is an important loss of income. And so there's just, I'm busy, I just have a busy life and I can't take time for that. And then there's lack of trust. So I'll just give you one story. So one of the teams that was offered to us for vaccination early on was the National Guard. And we had a community member that's a community-based leader who said, yes, let's do it. And then the county stepped in and blocked it and said, nope, can't have the National Guard here. They basically, because their concerns over community problems or concerns over the National Guard. It was really strange because this woman is an elected official and leader in her community. And she was like, no, let's just do it. So there's some politics there that are interesting, but basically this lack of trust delayed the delivery of vaccines. Well, what does that mean? Delays mean loss of life. And so that's how trust gets in the way. So I think there's much more, too much is made of the sort of concerns over safety and efficacy, and not enough is understood about the impact of access, basically. And so I think we just need to do a lot to build trust, and also to really help people understand they don't have to be afraid. They aren't going to have their immigration status compromised. They're not going to have family members who might be deported. They're not going to face huge bills. And the employers, the biggest thing I think about is incentives. And it's like, why aren't we, we're trying to incentivize people to do things that are not necessary. There's some reasons why they're not, stepping up to get the vaccine. And it could be with their employers. A lot of it that I've heard is with their employers. Why don't we require employers to give employees time off to get vaccinated? That's where I think we need to have more action.
Thank you. That's great.
Other questions?
If I can just interrupt for 1 second, I'm going to put up a QR code on the screen. And so this is for completing the survey evaluation. It's just a slightly quicker, easier way to do it. If you point your camera phone at this QR code here, it should take you directly to the website, and you can do the evaluation for all today's talks very easily. And there is even a raffle for a $25 Amazon gift card. We're going to be giving a few of those away. So please just leave us your email or a way to contact you. All right. Thank you.
All right.
Luisa, it looks like she has her
Yeah,
hand.
Luisa, do you have a question? Yes.
Hi, thank you for a great lecture. I love the platform Adios COVID-19. I'm working on a project with another scientist from RICMAR on COVID-19 vaccination, focusing on increasing vaccination with underserved Latino families in LA.
Mm-hmm.
So one thing I have a question is, here in LA, there are a lot of incentives, right? So right now you can get, I guess, a Dodgers ticket, you can get, so actually with our conversation with the community, there has been some concerns about these incentives. And then there is this sort of lack of accessible information for the Latino community in Spanish. So I want to hear what are your thoughts on that. I don't know if, in Washington, you have the same issue, that there is some levels of distrust when it comes to these very generous incentives. So I'm curious if you have encountered that too.
Yeah, so there's been there's a lot of incentives in place, and I'm more sort of, I don't know, maybe they help. But I don't know really. There's some theoretical potential downsides to to people who are hesitant. They may see vaccines as a bribe and like, why? I mean, incentives as a bribe, and why would you? It's good for me anyway. In terms of Spanish accessibility, we have really, so anyway, anytime, try to speak through the media, Spanish media. So working with, we've through the center, we had a collaboration with the Department of Health and with Univision and with, there's a couple of radio stations and CMAR community health centers to host panels where we have Spanish speaking physicians and others, talking about the vaccines, trying to share information through Facebook. Again, any social media, any sort of, and through schools. So we recently are working with school districts, to try to reach families and to talk about why people should be getting vaccinated. So, all I can say is that I have found working with community-based organizations is the best way. And so and that takes years. I mean, it is only because we've had this center for years that we're I can get on the phone and call somebody at a community-based center. They know who we are. They say, oh yeah, sure. And they'll talk to us. And then we try to mobilize resources. So the other part to it is having connections with the health department so that you can bring resources to bear. I mean, it's just, if you can get this going, it's really great work. But that's the approach, I think, that works.
All right. I want to thank you, Leo, for joining us today. We would love to have you hear our scientists talk, but maybe your sailboat's calling. So please stay as long as you can. And I'm going to turn the floor over to Kenrick to introduce our next speaker. Thank
Bye-bye.
you again.
Yeah, Leo, thank you so much. I really appreciate you taking the time, and it's good to see you even if it's by video. So keep up the good work.
Thank you.
All right, so that was terrific, and I think we can go ahead